Okay. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to the second revision session for master degree students at the full semester of 2025. Last time we revised quickly hypothyroidism and mainly acromegaly, but we touched upon the macroadenomas in general with the NOS classification, and I revised also the craniopharyngioma quickly, right? And then we started revising hypothyroidism, okay? So today, inshallah, we are going to continue the rest. But before doing that, I think I promised I would show you the video on, or the videos on how
دكتور الصوت
to
بيقطع.
الصوت بيقطع. I don't know what to do. Is the sound okay now?
هو دلوقتي كويس بس بيقطع فترة طويلة كده وبعدين يرجع تاني.
Yeah, I feel there is a lag in my sound, right? You mean there is a lag?
هو دلوقتي مظبوط.
There is a lag in my مظبوط. طيب, I don't know what to do because I'm sitting very near to the router. And I'm not using any Bluetooth or anything regarding the headphones and microphones.
الصوت
Sorry?
قطع الصوت قطع آخر حاجة دكتور، ما سمعناش حضرتك قلت إيه آخر حاجة خالص.
I was telling you that I promised I would show you a video on how to elicit the delayed ankle jerk relaxation time in cases with hypothyroidism. Remind me if I did, because I remember I didn't show it to you, but I promised I would. Can you hear me, Dr. Sama? Can all of you hear me?
أيوة دكتور سامعين. احنا ما شفناش
Okay, so I will start by doing just that because one second, because one minute. Can you still hear me?
دكتور للأسف هو الصوت قطع.
Can you hear me now? I didn't say anything. I didn't say anything. Can you hear me now? Can you hear me now?
أيوة دكتور.
Now yes.
Okay.
Now yes.
Okay. Now I'm going to start showing you the video on ankle jerk relaxation time, how it is elicited. Remember that a quick revision of the muscle action potential that we studied many years ago in our musculoskeletal module. Remember the muscle action potential of skeletal muscles is composed of a contraction phase and a relaxation phase. Both of them they have the same amplitude and they have the same duration, okay? But in hypothyroidism, the contraction phase becomes of a smaller amplitude and the relaxation phase becomes much delayed. So I'm going to show you two videos. The first video is showing you a normal muscle action potential. There are two subjects in the video seen, one wearing a white shirt. This one is the normal, the euthyroid person, right? While the other patient who is wearing like a dark red or dark brown shirt has primary hypothyroidism, and you will notice the difference that the contraction phase becomes much less than normal and the relaxation phase becomes much delayed. Let me open the video first and then I will share it with you. But then you just let me know if you can see the video or not. Okay? I hope you can still hear me. So can you see the video? Can you see the video? Huh?
Yes, doctor.
Okay, so this is the normal, the healthy person wearing the white shirt. This is the proper way to elicit delayed ankle jerk relaxation time. We don't do it the way we were taught to do in neurology, right? The patient has to be kneeling with both knees on a chair, with both feet suspended in air like that, and holding the back of the chair with both hands in order not to fall down. And if you are using this triangular reflex hammer, because the tendon Achilles is a big tendon, you tap with the broad area of, or the broad part of the reflex hammer. All right. And while tapping, you ask the patient to clench his or her teeth in order for positive reinforcement. So please watch carefully. You see, contraction, relaxation, both of them are of equal amplitude and same timing. Here, you notice the amplitude of the contraction is much less than normal. Let's watch again. And the relaxation time is much delayed. Did you notice the difference? Let's watch again. Can you notice the difference? Contraction, relaxation, immediately of equal amplitude and equal duration. But here the contraction phase is much reduced in amplitude and the relaxation time is much delayed. Did you appreciate this difference? I hope you can still hear me. Okay. Now, I mentioned, maybe I mentioned or I didn't, I don't remember. Last time I mentioned that hypothyroidism tends to occur in older age groups like 50s and above or 60s. In this age group, patients usually have osteoarthritis, which is a degenerative disease of the joints, okay? Of weight bearing, mainly joints. So they wouldn't be able to kneel with both knees like that. So in that case, what do? You ask the patient, like in this video. I hope you can see the video now. Can you see the video? Yes. So this is an elderly lady, of course, from India or Pakistan. She's standing on the right foot and she's kneeling with on the left knee, okay? And here the doctor is trying to elicit the ankle jerk relaxation time. You notice the contraction phase is of diminished amplitude and the relaxation time is delayed. Okay, let's watch it again. You see? Can you appreciate? Okay, so after you finish examining the left side, you ask the patient to stand on her left foot and kneel on the right knee on the chair. Clench her teeth while you tap over the tendon Achilles to examine the right side as well. Okay? Okay? Any problem so far? So this is the delayed ankle jerk relaxation time. Now let me share the presentation with you. 1 second. Okay. Just let me know once you see it. Can you see it now?
Yes, doctor.
Okay, so reminding you of the intended learning outcomes, by the end of today's session, you will be able to enumerate the symptoms and signs of hyperthyroidism. You're going to be able to diagnose the presentation of hyperthyroidism according to etiology, like we're going to see. You're going to be able to detect the atypical presentation of hyperthyroidism in children and the elderly, again, like in hypothyroidism, like we have seen the last time. And you're going to be able to differentiate the type of goitre in the different causes of hyperthyroidism, like we're going to see in the pictures. You're going to be able to diagnose the different eye signs in Graves' disease. This is very important. I don't know whether you saw actually in the case you have seen in the meeting. Whether you have seen eye signs of Graves' disease or not, I don't know. And then you're going to be able to describe the different methods of detection of exophthalmos. This is very important as well. And then you're going to be able to differentiate the different types of thyroid nodules. And finally, you're going to describe the different imaging techniques in thyroid diseases, including thyroid ultrasonography and thyroid scintigraphy. Okay? So Let me shift to hyperthyroidism. We have covered all that last time. So now coming to hyperthyroidism. Can you see my slides in slideshow? I hope you can hear me as well. Can you see me? Can
لا
you
يا
hear
دكتور
me?
للأسف مش باين.
The slides are not visible?
لا
Who
يا
is,
دكتور.
all
لا
of
يا
you
دكتور
ولا
هي
مش
مين؟
باينة
باين.
عندي.
دكتور خلود can see. دكتورة خلود.
لا يا دكتور للأسف مش باينة عندي.
طب you can log out and log in again because I hope the rest of you can see the slides. Can the rest of you see my slides?
Yes.
Huh?
Yes, doctor.
Okay, so the problem is from your side, Dr. Khulud. So you can log out and log in again. Okay? I will wait for you, but don't take forever, yeah? Okay. Which Dr. Khulud was it? It wasn't Dr. Khulud Muhammad. Yes, the other one. Dr. Khulud unverified. Yeah. Can you see my slides now, Dr. Khulud? Dr. Khulud.
يا دكتور.
Okay. Okay. Great. So let me continue. Are my slides in slideshow now?
Yes.
Okay. I hope they are moving as well. Okay, so coming to the clinical features, we agreed last time that clinical features include the symptoms or the complaints of the patient as well as the signs. Coming to the symptoms, again, all female patients, because hyperthyroidism is also predominant in women more than men. They come complaining of all the cosmetic pertaining symptoms, okay? So she will tell you, I have increased appetite. I keep eating all day long, and even I wake up by night feeling hungry and I eat. In spite of that, I lose weight. All right. She will tell you, I'm irritable. I'm restless. I keep fidgeting all the time. My behavior has changed. I have become more aggressive. I quarrel with my children, with my husband, with the neighbors. I quarrel even with myself. Okay, this is abnormal, right? And then there is malaise. The patient feels malaise. She may feel stiff, but this is not a very common complaint. But she will also complain of muscle weakness. Okay, muscle weakness, by the way, is very common in most of the endocrine diseases, as you have noticed by now, in hypothyroidism, in acromegaly, in Cushing syndrome or disease, in hyperparathyroidism, whether primary or secondary, okay, and in hyperthyroidism as well. So the muscle weakness, again, affects the shoulder and pelvic girdle muscles. So she will tell you the same. No need to repeat, like we have mentioned with acromegaly last time and with hypothyroidism. But she will also complain of tremors, fine tremors in the hands. Maybe the tremors affect all the body, the whole body, depending on the severity. But tremors, if she's a housewife, she will tell you, I keep the dishes and the cups and the glasses keep falling off my hands while washing the dishes, and I break a lot of things because of my tremors. Okay. Some people complain of choreoathetosis. Now, a quick reminder of what that is. Who can tell me what chorea is? Chorea. Both of them are involuntary movements, by the way, like tremors, right? But there is a difference. What is chorea? Who can tell me? What is chorea? Chorea is an involuntary movement affecting the skeletal muscles, which is jerky in time and in place. This means that you don't know when or where which muscle group or muscle groups it's going to affect. This is the chorea. It's jerky like that. Okay, sudden jerky movement. And athetosis is another involuntary movement affecting skeletal muscles, but here it is a twisting form of movement. It may affect the length of the limb or even the trunk. Okay, so when both of them are combined together, it's called choreoathetosis. But this is not very common, actually. But it's for the sake of completion, it's written in textbooks, so this is why I'm telling you about it, okay? And hyperthyroid patients may also complain of breathlessness. They feel dyspneic, as if they were running for several kilometers, okay, at rest, that is. And palpitations, of course, why? Because the mechanism of palpitations, or in general, palpitations occur whenever there is change of rate, either tachy or bradycardia. In hyperthyroidism, there is, of course, tachycardia, or whenever there is change of the force of cardiac contraction. Here, of course, the force of cardiac contraction is increased, right? And whenever there is arrhythmia. So elderly patients with hyperthyroidism may have arrhythmias, and the most common of which is, of course, atrial fibrillation, right? So this is the mechanism of palpitations. Of course, heat intolerance. In the middle of winter, the hyperthyroid patients, they usually come wearing very light cotton clothes, and they are very much sweaty, and they feel very hot. Open the windows, open the AC, even while the rest of the patients in the ward feel very cold, and they have brought additional coverings from home, okay, because they feel very cold. And some patients complain of itching. This is a commonly neglected symptom. It's not very common, but we tend to see it as well. Itching. So the patient presents to the dermatologist. The dermatologist examines the patient, but he or she, they don't see any rashes or anything, but they should suspect that the patient may be hyperthyroid, okay? And the rest of the symptoms include excessive thirst, of course. Why? Because there is excessive sweating. So if the patient doesn't drink adequately, the patient will be dehydrated, feeling thirsty all the time, okay? And maybe also hyperthyroidism can also lead to secondary diabetes mellitus, okay? So maybe the patient developed diabetes mellitus not knowing, so she feels thirsty and she has polyuria. And okay, vomiting, diarrhea. Actually, if you analyze diarrhea, you will find that it is some sort of hyperdefecation rather than diarrhea. Who can tell me the difference between both? Is there a difference, or are both of them the same thing? What is the difference? What is the difference? Come on. You're wasting a lot of time.
Hyperdefecation is an increase in the number of motions, but diarrhea is a
Yes.
change in the consistency of the motions.
You have to complete it. In hyperdefecation, there is increased number of motions that are well formed, okay? But in diarrhea, there is also increased number of motions, but they are liquid, okay? This is the difference between both of them. Very good, okay? So actually, most of the patients I have seen, they had hyperdefecation. So you need to distinguish that. And of course, how can we know that? By asking the patient about their bowel habits, how they were before they got sick. Okay? So she will tell you, I used to defecate once every day or every 2 days, but now I defecate like 5 or 6 times a day. You will ask her, are the motions liquid? She will tell you, no, they are well formed. So this is hyperdefecation. If she tells you yes, then this is diarrhea. Is it clear? Then the eye complaints, of course, the patient they vary. She may tell you, I have a stare, unilateral or bilateral, like we're going to see in the signs. She may tell you, I have, if she has a lot of eye changes, or if she has Graves' eye disease or Graves' ophthalmopathy, she may even develop corneal ulceration. She may have photophobia and excessive lacrimation and so on. Okay, so the eye complaints vary depending on the underlying etiology and severity, of course. Goitre, of course. Goitre, all causes of hyperthyroidism, like we're going to see, have an enlarged thyroid gland, except, of course, the factitious thyrotoxicosis. The factitious thyrotoxicosis is the secret consumption of Eltroxin or euthyrox in order to get sick, to gain benefit from this sickness, okay? There is no goitre in factitious thyrotoxicosis. And female patients complain of oligomenorrhea. We have discussed last time how we inquire about the menstrual cycle, so no need to repeat again. Male patients complain of loss of libido, and they have gynecomastia. Why do you think here there is loss of libido? In hypothyroidism, there was associated hyperprolactinemia. But this is not the case here in hyperthyroidism. What is the mechanism of loss of libido here? Who can tell me? Hmm? Who can tell me?
هو أنا مش متأكدة يا دكتور، بس هي ليها علاقة بالسكس هرمون binding globulin.
Type. There is hyperestrogenemia. In hyperthyroidism, there is hyperestrogenemia, which is the cause actually of palmar erythema, like we're going to see in the signs. Okay, so this hyperestrogenemia in men will definitely cause loss of libido, and it can contribute also to gynecomastia. Gynecomastia, by definition, means breast enlargement in a male. So this word doesn't apply to female subjects, because by default, female subjects from puberty till they die, they have well-developed breasts. Okay, so this is normal for women, but this is abnormal. Breast development in men is abnormal, and it's termed gynecomastia. Okay, and in this context, we have to differentiate between true and false gynecomastia. What does it mean? True gynecomastia and false gynecomastia, or pseudo, pseudo. What does it mean? Is there a difference? Huh? What is the difference? Huh?
pseudo gynecomastia بتبقى عبارة عن fatty tissue بس.
In English, please, because Dr. Moaliso doesn't understand Arabic, and he is attending with us. Yes.
Pseudo gynecomastia is only increase in fatty tissue deposition in the breast.
Exactly. Exactly. While true gynecomastia, there is actually a breast tissue. How can you detect that? Yani, we're talking about the symptoms now, but in the signs, how can you detect the difference? How do you do it?
True gynecomastia, by examination, it appears as disc-shaped or disc-like shape below the nipple, or button-like shape.
Yes. Yes. It actually doesn't appear. You have to palpate. Yani, in order to distinguish true from false gynecomastia, you have to palpate. Okay, you put your index finger on the nipple of the patient. So in an obese, suppose you have a patient with obesity. In obese men, the breasts tend to be, they appear to be enlarged, but they're actually not enlarged. This is increased fat. So in that case, you put your index finger on the nipple of the patient. If you can feel the rib, the underlying rib, okay, below your index finger, this means that it was fat all the time. Okay, but if there is an intervening disc of breast tissue between your palpating index finger and the underlying rib, this is true breast tissue. Is it clear? Okay.
Yes.
You don't palpate from side to side, you palpate like that. Suppose this is the patient. If you can see my picture, this is the patient lying flat. Okay, and this is the nipple. You compress on the nipple with your index finger while the patient is lying in bed. Okay, is that clear? Okay, now
Yes.
onycholysis. Okay, great. Onycholysis. Don't be afraid of difficult words. Onycho is Greek for nail, and lysis, you know the word lysis. Okay, I will show you pictures thereof in a minute. It can be both a symptom and a sign. Because why can it be a symptom? Because remember, the patients are ladies. Those of the most females, at least abroad, they are very interested in taking proper care of their nails. And all of a sudden, the female patient notices that she cannot keep her fingernails clean. There is dirt always under the fingernails. Why is that? Because the fingernail grows away from the nail bed. So there is space between the nail and the nail bed in which dirt accumulates. So she may come and tell you, look at my fingernails, doctor. Of course, you see what is wrong with her fingernails, but again, listen to her complaints. I cannot keep my fingernails clean. Okay, this is a common complaint. In children, again, the presentation is atypical by tall stature. An excessively tall child, the mother comes running. My child is the tallest in class. I'm afraid that he or she, they may have developed, they are starting to develop gigantism, okay, or precocious puberty, okay. Before working up the child for these conditions, please exclude hyperthyroidism as a possible cause. Remember, it's quite the opposite. In hypothyroidism, the child may present with short stature or slow growth velocity, while here the child presents with tall stature, okay? And of course, excessive sweating, as I mentioned. This is onycholysis. This is, remember, this is seen only in Graves' disease, not in the multinodular toxic goiter and not in the toxic adenoma. This is the hand of a patient, like it's the left hand of the patient, okay? She's trying, or the right, it's the right hand. So she's trying to do a fist like that. This is the thumb. This is the index finger. This is the middle finger, the ring finger, and the little finger, okay? And this is the nail bed. It has two parts. The pink part, which is growing on the nail bed, and the yellowish part, the whitish yellowish part, which when our fingernail. Look at the pink line distinguishing the pink area from the yellowish white area. Here it is regular. The ring and the little fingers. You notice it's irregular. Not only that, but it's almost reaching till half the nail. This means what? That the nail grows away from the nail bed. So of course there will be a space. This space is where the dirt accumulates. And here even the doctor can put a wooden rod between the fingernail and the nail bed. Of course, this is an extreme condition just to show you, but it rarely reaches this stage. Yeah. Okay, is it clear? So okay, for instance, male patients, they don't bother. It doesn't bother them. But you have to detect it as a sign. All right. Now coming to the signs, these are the manifestations to look for and detect while examining the patient. Again, tremors. Tremors, you look for them in the outstretched fingers. With the fingers should be fanned like that, if you can see my picture. If you can't appreciate the tremors well, then you put just a piece of paper over the dorsum of the hand of the patient. You will notice that the piece of paper is starting to tremor as well. And you can see the tremors in the protruded tongue, provided it doesn't touch the upper or the lower incisors, okay? You ask the patient to protrude her tongue like that. It should be fixed, okay? But if it keeps tremoring, then this is tremor, okay? Hyperkinesis. Hyperkinesis means excessive movement. This is more noted in children. And in that context, children are usually punished in the classroom because they are restless. They have hyperkinesis. They are moving all the time. They stand up, they sit down, they look to the right, they look to the left. They are really distracting the teacher and the classmates. So often they are being punished and sent out of class, okay? While the poor child is hyperthyroid with nobody noticing, okay? Again, remember psychosis, exactly like hypothyroidism. So psychosis, it's a form of psychiatric, no insight. So many times the husband or the children of the patient bring the affected family member to the psychiatrist complaining that she has abnormal behavior, all right? Tachycardia or even atrial fibrillation. Rapid heart rate in absence of fever, or with very mild fever, because note also please that in hyperthyroidism the basal metabolic rate will be elevated, so this may cause very low-grade fever, in absence of infection, that is, okay? So suppose the patient has a temperature of like 37.5, okay, but the heart rate is 140. This is significant tachycardia, right? And not explained by the fever. Or even you can feel a completely irregular pulse, right? So here you have to doubt that the patient may have hyperthyroidism. And it is even said that elderly patients presenting with heart failure or atrial fibrillation that are not explained should have their thyroid functions checked, okay? And of course, the character of the pulse is a full bounding pulse, because there is a wide pulse pressure. Why? Because they have hyperthyroid patients have systolic hypertension, while the diastolic blood pressure is low. Who can tell me why? Why is the systolic blood pressure high and the diastolic blood pressure low in hyperthyroidism? Who can tell me why?
Systolic is high due to tachycardia. Diastolic is low due to peripheral vasodilatation.
Not only tachycardia, Dr. Nadine, very good, but not only tachycardia, but there is also increased force of cardiac contraction. Remember, so the stroke volume is very much increased, sharing in the increase in the systolic blood pressure, and the diastolic blood pressure is low because there is peripheral vasodilatation, like you mentioned. Very good, excellent. Okay, can you still see my slides? Okay, there are warm vasodilated peripheries. Remember, in hypothyroidism, the peripheries were cold, but here there is vasodilatation and there are sweaty, hot palms, all right? Now, heart failure, remember, I told you, patients with hyperthyroidism, particularly elderly patients, can present with heart failure. And in that context, this type of heart failure is a high output heart failure because the cardiac output is increased, okay? And those items I have marked with a different color and asterisks: exophthalmos, the lid lag and stare, the conjunctival edema, the ophthalmoplegia, and the periorbital edema. They are only seen in Graves' disease, okay, like I'm going to show you in the pictures, okay? And again, there is a goiter I mentioned in all types except the factitious thyrotoxicosis. But remember, bruit, a palpable thrill over the upper poles of the thyroid and an audible bruit over the upper poles of the thyroid gland are seen only in Graves' disease, not in the other causes, okay? And of course, weight loss. If you are the attending physician of the patient, so you know in the health records of the patient, you know she weighed like 70 kilograms 3 months ago. Now she is weighing only 55 kilograms. So this is significant weight loss, okay? And of course, proximal myopathy and even proximal muscle wasting. If the patient didn't complain of muscle weakness, then in examination, in the signs, you have to check for the muscle power of the flexors, the extensors, the abductors, and the adductors of the shoulder and hip joints. And you have to also look for proximal muscle wasting. Okay, but this is not very common. Onycholysis, remember, onycholysis can be a sign as well. Okay. Let me put the charger before my laptop cuts off. A second. Can you still hear me?
Yes.
Okay. So remember, onycholysis can be a symptom and a sign. All right. A palmar erythema, I'm going to show you how it looks like in a second. Graves' dermopathy, thyroid acropathy, and pretibial myxedema are again only seen in Graves' disease. This is why I have marked them with an asterisk and put in a different color. So this is palmar erythema. You see, the center of the palm appears relatively pale compared to the thinner and hypothinner eminences, as well as the heads of the metacarpal bones. Who can tell me what are the other causes of palmar erythema that you know? We are revising in general. This is the endocrine cause, hyperthyroidism. What other causes? Yes, tell me.
Pregnancy.
Yes, excellent. Very good.
Liver cirrhosis also.
Yes, not liver cirrhosis, but liver cell failure. It's a manifestation of liver cell failure. Okay. And what else? Something else missing? Chronic respiratory failure. Okay. All the causes that cause peripheral vasodilatation. And in the context of pregnancy, what's similar to pregnancy is if a lady is taking oral contraceptive pills, she will have also palmar erythema like that. All right. So it's very common. So remember to look for it. And then this is Graves' dermopathy. You see, this is it. This looks like a peau d'orange or the orange peel appearance. You see, it looks purple, red in color. You can observe it or look for it over the shin of the tibia and on the dorsum of the foot. You notice there are some pits, and so it looks edematous. If you try to elicit edema, you will find it is a non-pitting type of edema, right? The same, the other name for it is pretibial myxedema. Pretibial, of course, because it is found on the tibia, but this myxedema often confuses people. Why? Because myxedema is the old name for hypothyroidism. So most of the students think that pretibial myxedema is seen in hypothyroidism. No, actually, it is seen in Graves' disease, which was the most important cause for hyperthyroidism. This is how it looks like, as if there is some pitting, edema or peau d'orange over the shin of the tibia, okay? So the clinical features of hyperthyroidism, as I mentioned, they depend on the underlying etiology, and they vary with the age, because the eye signs, the pretibial myxedema and thyroid acropathy occur only in Graves' disease, okay? And this pretibial myxedema that I have just shown you is an infiltration on the shin of the tibia, essentially occurring only with eye disease. So if your Graves' disease patient doesn't have Graves' ophthalmopathy, you don't expect to find pretibial myxedema, okay? Again, thyroid acropathy. This is very rare, and it consists of clubbing with swollen fingers and periosteal new bone formation, like I'm going to show you in a minute. And in the elderly, remember, a frequent presentation is with atrial fibrillation, other tachycardias, and or heart failure, often with few other signs. This is the atypical presentation of hyperthyroidism in the elderly, all right? So here, let's revise. This is a very important clinical sign, clubbing. This is the normal finger. Look at your finger tangentially like that, if you can see my picture, okay? This here is the angle between at point B. You see, line DB produces this obtuse angle with line BC, okay? If this angle is lost, or it becomes straightened, like here, this line will become a straight line, like here, DBA. This is grade 1 clubbing, actually. By definition, clubbing means obliteration of the angle at the nail of the bed, this one, okay? Clubbing has 4 grades, as you all know. Grade 1 is obliteration of the angle. Grade 2 is this. There is obliteration of the angle in addition to parrot beak appearance of the fingernail, or increased convexity of the fingernail, like you can see in this panel B, okay? Grade 3 clubbing is, like we can see here, there is obliteration of the angle with increased convexity of the nail, but there is also enlargement of the terminal phalanx, what we call drumstick appearance, okay? Grade 4 clubbing is the same like drumstick, but in addition, there is broadening of the wrists and ankles. Why? Because there is subperiosteal bone deposition around the ankles and the wrists, okay? And the grade 4 clubbing was called pulmonary osteoarthropathy because it was first described with the pulmonary causes of clubbing. So this brings us to the next question. What are the causes of clubbing? You know, we are revising. What are the causes of clubbing? Who can tell me? This is internal medicine. No.
Bronchiectasis.
Sorry?
Bronchiectasis.
Yes. Yani, for the sake of organization, I want your brain to be organized. You mentioned pulmonary causes of clubbing, cardiac causes of clubbing, liver causes of clubbing, GIT causes of clubbing, endocrine causes of clubbing, and then if you don't find any cause, you just mention idiopathic or familial. This way, you will not forget anything. Okay, so regarding the pulmonary causes of clubbing, Dr. who was it? I don't remember who said. I didn't see. Dr. Sama or Dr. Nadine? She mentioned bronchiectasis. طب what else? Dr. Sama, was it? Right?
أيوة دكتور.
Oh.
Lung cancer.
Yes, lung carcinoma. Okay, what else? Something similar to bronchiectasis. You can further subdivide into pyogenic or pyogenic lung diseases
Cystic
like
fibrosis.
yes, bronchiectasis, cystic fibrosis, lung abscess, and empyema. These are the pyogenic lung diseases, okay? And then we have lung cancer or bronchogenic carcinoma. Something similar to it is mesothelioma. This is a malignant tumor of the pleura, okay? And don't forget TB, because TB is is in the differential diagnosis of almost all diseases. These are the lung, and don't forget the very important one associated with cyanosis, interstitial lung disease, okay? Interstitial lung fibrosis, okay? So what are the cardiac causes of clubbing? We have two
Infective
yeah.
endocarditis.
Cyanotic congenital cyanotic heart disease and infective endocarditis. Very good, excellent. What are the liver causes of clubbing? Who can tell me?
Primary biliary cirrhosis.
Yes. What else?
Primary sclerosing cholangitis.
Yes, very good. And sometimes also in autoimmune hepatitis, you can appreciate clubbing of the fingers. Very good. What are the GIT causes of clubbing? Who can tell me?
IBD?
Inflammatory
Yes,
bowel disease.
exactly. Inflammatory bowel disease, which includes ulcerative colitis and Crohn's disease. Excellent. And what are the endocrine causes of clubbing? I have mentioned Graves' disease, Graves' acropathy. Is there something else that may cause clubbing or pseudo-clubbing, PSEUDO? Remember, primary hyperparathyroidism, because it can cause resorption of the terminal phalanx, which may appear clinically as clubbing, while it is not, okay? And if you don't find any of these causes, then it is idiopathic or familial. You will find more than one family member having clubbing. Is it clear? Now, the second question is, how do we detect clubbing? This is the very famous Shamroad sign. No need to remember the name, but the window test, okay? You ask the patient to put the corresponding fingers against each other's, and you look for the rhomboid-shaped window at the area of the angle of the nail bed. And at the same time, you will notice that both nails are adjacent to each other. If there is clubbing, like here, where is the space? It's not visible. And the nails, they are diverging, okay? Another important way to test for clubbing is by looking, you put your finger against the patient's finger, like that, if you can see my picture, okay? Assuming that you are normal, your angle is here. So you compare your own angle with the patient's angle. If the patient has a preserved angle, then there is no clubbing. If the patient doesn't have an angle, then this means that the patient has clubbing, right? And there is another test that is not very commonly known among students, but it is written in textbooks, in clinical textbooks, which is called the phalangeal depth ratio. This is the normal finger. You will notice that the distal phalangeal depth is smaller than the interphalangeal depth, but in clubbing, this becomes reversed. The distal phalangeal depth becomes larger or bigger than the interphalangeal depth, okay? But the best test actually to test for clubbing is what is the fluctuation test. Okay, so let me show you a very, very short video on how to elicit fluctuation. Let me share the video with you. It's opening. Am I going too fast? Till now, anything that is problematic? Let me first explain the video to you. Is the video visible to you now? Huh? Can you see the video?
Yes.
Yes.
Okay, so let me explain what you see. This is the thumb of the left hand of the doctor. Okay, this is the index finger of the left hand of the doctor. This is the right thumb, okay, of the right hand of the doctor. This is the right index finger of the right hand of the doctor. And here is the finger of the patient, okay? The doctor is doing what? He is compressing at the area of the nail bed, at the junction between the nail and the skin here, okay? So he's compressing with this finger this index finger and feeling for fluctuation with the other finger. Let me show you the video. Can you appreciate that there is sponginess as if it's moving? Let me show it again. Can you appreciate this? Is it clear? Huh? Did you see it?
Yes.
Okay, great. Okay, so this is how this is the best test actually to test for clubbing, right? Let me share the slides again. Where we, yes, here. Can you see my slides again? Can you
Yes,
see my
doctor.
slide? Okay. But they're not in slideshow, right? They're not in slide. Now they are in slideshow. Okay. So this is how to test for clubbing. Okay. Okay, is it clear?
Yes.
Okay. Okay, so this is thyroid acropathy. You see there are eye manifestations, pretibial myxedema, and clubbing. This, when you see all three of them, this is thyroid acropathy. Again, this is very evident. You see the patient has a diffuse goiter in the neck, eye signs, periorbital puffiness, and she has exophthalmos to a mild degree. She has pretibial myxedema, and she has clubbing as well. Very evident, okay? I hope it's clear. Okay, so actually the clinical features of hyperthyroidism are usually evident, but thyroid function tests are mandatory in any patient with atrial fibrillation, as I mentioned, particularly if they are elderly, okay? And the so-called apathetic thyrotoxicosis is seen in some elderly patients who present with a clinical picture that looks more like hypothyroidism. But when you do the thyroid function tests, you discover that this elderly patient is hyperthyroid. And there may be very few signs, and so a high degree of clinical suspicion is essential. All right, so this is the atypical presentation of hyperthyroidism in elderly patients. Okay, again, in children, they can frequently present with either excessive height or tall stature or excessive growth rate or growth velocity, behavioral problems like hyperactivity, okay, which is often misdiagnosed or wrongly diagnosed as having ADHD, okay, and weight gain rather than weight loss. Because they feel hungry all the time, so they consume a lot of high caloric content food items like chocolate, biscuits, chips, and so on. So they gain weight instead of losing weight like adults. Is it clear? So these are the atypical features in elderly and in children. Okay? So far, any problems? Now, let's look at goiter in hyperthyroidism. This is diffuse goiter in Graves' disease. You see, this is the neck of a young lady showing diffuse goiter. There are no visible nodules, okay? And this is a young gentleman of African origin. You see, he has a goiter as well, a diffuse goiter as well, okay? Watch, look at the eyes. Do you think here the eyes of this young lady, they are not visible, but here the eyes of this gentleman are visible. Do you think this gentleman has a staring look or exophthalmos? Who can tell me? Mm. Mm. Who can tell me?
They look more like of exophthalmos, but would have to sit better from the angle, I think.
Okay,
we will.
Angle. Okay, you are right. He has exophthalmos, but we can see, you can appreciate exophthalmos from the front as well, like I'm going to discuss with you in a minute. Okay. Alhamdulillah. But you are right. He has exophthalmos. Okay. What did you want to say, Doctor? Who was it who wanted to talk? Dr. Sama, I assume. Dr. Sama, what did you want to say?
ستيرنج لوك كنت هقول ان احنا مش هنعرف نحدد هو اكزوثالموس ولا لا غير فعلا لما
in English, please. In English, Dr. Moliso doesn't understand what you're saying.
I would say he has staring look rather than exophthalmos. We need better examination.
No, I will tell you. When you look to the patient from the front like that, if you look closely, there is a rim of sclera between the upper eyelid and the upper limbus of the cornea, okay, in both eyes. But if you look closely, you will appreciate there is another rim, very fine rim of sclera between the lower limbus of the cornea and the lower eyelid. So this means that actually the eye globe is pushed out, okay? So this means he has exophthalmos. I will get back to that again when we discuss the methods of detection of exophthalmos. All right, very good, Dr. Molis. Nice try, Dr. Samad. Anyway, look at the neck of these patients. Here you can see she's like in her late 30s or early 40s maybe, and she has a moderately enlarged thyroid gland, right? But if you look at the surface by inspection, and she doesn't have eye signs, right? If you look at the neck, it doesn't appear diffuse. No, the surface is bosselated, right? As if there is a nodule here, a nodule there, another nodule there, a nodule here, and another nodule here. So it appears to be composed of multiple nodules. So it's a toxic multinodular goiter. Here, actually, we can't see the face of the patient, but we can see that the patient is a bit older, right? Why? Because there are folds of aging in the neck of the patient, right? In addition to the bosselated surface, there is in addition to the moderately enlarged goiter and the bosselated surface, maybe this patient may have also retrosternal extension. Why am I saying that? Because here you can see dilated veins, right? These are dilated veins. Can you appreciate them? What's the difference between dilated veins and visible veins? Who could tell me? Is there any difference? Huh? Is there any difference between dilated and visible veins? Dilated veins are like here. If you look closely, you will notice that they are tortuous, like varicose veins, right? And they are elevated above the level of the skin. They are not flush with the skin, but visible veins are just going to be visible. And you can see bluish structures in the skin, but they are not palpable. If you try to palpate them, they are not elevated above the level of the skin. Is it clear? Okay. Here, these are two young ladies having a solitary toxic nodule. Here, the trick is maybe this lady has a dominant nodule in a toxic nodular goiter. Why am I saying that? Because the neck appears as if there is a goiter, right? You are justified to say solitary toxic nodule if there is no palpable goiter, except the nodule here, okay? In that case, it is a solitary toxic nodule. But if you can appreciate that the thyroid is a bit enlarged, the patient may have multiple subcentimetric nodules that are not clinically palpable, but they are visible on ultrasonography, but she has a dominant nodule, okay? So this is very important to differentiate whether the patient has a solitary toxic nodule or a dominant nodule in multinodular goiter. Is that clear? Any problem so far? Okay, so like you know, this is the way to palpate the thyroid gland, standard method. Now coming to the eye signs in Graves' disease. These are very important. Remind me, the patient you have seen in the scientific meeting, did the patient have any eye signs? Huh? Can you still hear me? Can you hear me? Am I talking to myself?
Yes, I can hear you, doctor.
Okay, type, why don't you answer me? Any question deserves an answer.
I didn't hear the question. Sorry, doctor.
The question was, you saw a patient with Graves' disease, right? In the scientific meeting, right?
Yes.
Did you or did you not?
Yes. Yes.
Huh?
Okay,
was the patient a male or a female? What was the patient? Female. Okay, did she have any eye signs?
Yes, she has exophthalmos.
Exophthalmos. Okay, let me revise with you the eye signs. She had exophthalmos only. Did you see the rest of the eye signs? Because I'm going to stop. Okay, so it's important that you can appreciate all the eye signs in Graves' disease. Now, let me show you the normal eye first in all of us. The upper fifth of the cornea from 11 o'clock to 1 o'clock. Okay? And the lower eyelid is flush with the lower limbus of the cornea at 6 o'clock. You all know that, right? From the ophthalmology. Now, if there is lid retraction, this is the first eye sign to be appreciated in Graves' disease. There will be spasm of the levator palpebris superioris, or the Müller's muscle, leading to a visible sclera, okay, above the upper limbus of the cornea, like here, okay? This is what causes lid lag. So this retraction of the upper eyelid can be unilateral, like in this patient, or it can be bilateral. In that case, it gives you a staring look, okay? كأنها مبرقة, a staring look, right? Or frightened look, but it's more, in all textbooks write it staring look, okay? This causes this other sign, lid lag. Let me show you the video. The video makes you appreciate this sign better. Let me open the video first, and then I'm going to share it with you. And always remember, in this video, the patient is wearing eyeglasses. Whenever you examine the upper eyelids, I mean the eyebrows, the upper eyelid, the lower eyelid, the cornea, or even the eye, in a patient wearing eyeglasses, then you have to ask the patient to put off her eyeglasses. Can you see the video now? Can you see the video?
Yes.
Okay, you see, the doctor asked her to put off her eyeglasses. Now, watch this eye, okay? The doctor is examining the extraocular muscle movement in each eye separately. Notice when she looks down, what happens? The rim of sclera enlarges, okay? Now she's examining concomitant eye movement. Notice that one eye moves better than the other. You see here? This is lid lag, okay? See this eye? When she's looking up and lateral, this eye doesn't move well. This means that the patient can have diplopia or double vision. Is it clear? You see, she's looking up, but this eye is not following. This is ophthalmoplegia. Okay? See the lid lag? And now the doctor is asking her to close her eyes for her because she wants to see if there is this Bell's phenomenon or not. With Bell's phenomenon, there is incomplete closure of the eyes, and the eye globe turns up. Okay? You want to see the video again? Did you appreciate the lid lag? Huh? You want to see the video
Yes,
again? Okay. Anybody wants to see the video again? Just tell me, and I will play it again. Could you appreciate the lid lag? With the lid lag, you ask the patient to remove the glasses, and then you move your finger very slowly you ask the patient to follow your fingers without moving the head or the neck, okay? Just with the eyes. So you will appreciate that normally in all of us, when the eye globe moves down, the upper eyelid follows immediately. But here in lid lag, since there is spasm of the Müller's muscle, the eye globe moves down, but exposing the sclera above the upper limbus of the cornea. Is it clear? You want to see the video again?
Yes,
Just
it's clear.
Okay, great. Back to the slides. So this was lid lag, okay? Can you see my slides again? Okay.
Yes.
Okay. Now, just a second. Okay. Slides are stuck. Okay. So so this is lid retraction, right? Lid retraction, to revise again, there is just spasm of the levator palpebris superioris, exposing a rim of sclera above the upper limbus of the cornea. But in exophthalmos, since the eye globe is actually pushed out of the orbit, you will appreciate the rim of sclera above the upper limbus of the cornea as well as below the lower limbus of the cornea. So this is one method actually to detect exophthalmos, like I have shown you with the patient with Graves' disease, the one of African origin, okay? So he had exophthalmos, okay? This is another patient with Graves' ophthalmopathy. She has periorbital puffiness in both eyes. She has exophthalmos. You can notice the rim of sclera above the upper limbus of the cornea, but if you look very closely, very early, a very small rim of sclera will be visible between the lower limbus of the cornea and the lower eyelid in both eyes. And she has also conjunctival chemosis, this red area here. If you look in the mirror, try and do it after we finish. If you look at the, look medially with your eye, and you will find at the insertion of the lateral rectus, there is a leash of blood vessels, very pink in color, very fine, okay? But since the conjunctiva is a very thin membrane stuck to the sclera, you cannot actually move it if you do this maneuver, right? If you try and push the upper eyelid from here upwards, you will not be able to move it. But whenever there is conjunctival chemosis, and chemosis means edema, whenever the conjunctiva is edematous, you will be able to wrinkle it if you do this maneuver. I simulated to when, for instance, if you're wearing a body with tight sleeves, if you want to wrinkle the sleeves, you won't be able to wrinkle them because they are stuck to your forearm, right? But if you're wearing a white coat over the long sleeves of the body, and you want to wrinkle them like that, like I'm wrinkling my jacket right now, okay? You will appreciate that it wrinkles. The same applies to the conjunctiva. I hope it is clear. Can you understand what I'm saying? Any problems? Okay, so exophthalmos can be unilateral, like here. And our colleagues at the ophthalmology department, they see unilateral exophthalmos a lot. For them, it can mean that there is a retroorbital mass or a retroorbital tumor. So after they have excluded that there is nothing retroorbital, they usually transfer the patients to us, okay? And a quick reminder, there is no association between hyperthyroidism in Graves' disease and exophthalmos, meaning that the patient can be euthyroid, but she can have exophthalmos, okay? Okay, and this exophthalmos can develop either with hyperthyroidism or even before developing hyperthyroidism or after being treated. And it becomes worse after radioactive iodine, like what happened to the famous singer, Egyptian singer, Kulthum. Okay? Or the exophthalmos can be bilateral, like here in this, why are these eyes so red while these eyes are not so red? It depends on the activity, actually, the activity score. We have the CAS score, the clinical activity score, by which we detect the activity of exophthalmos. But here you can very clearly see that it is exophthalmos, not, and she has even excessive lacrimation. There is a tear on her right cheek. There is a rim of sclera above and below the upper and lower limbus of the cornea, here and there. Here, in addition, there is conjunctival chemosis, which not only affects the lateral, the area of over the medial recti as well. Is it clear? Any problems so far? Type. Now, how do we detect the exophthalmos? I told you I would tell you. The first thing is the rim of sclera below, when you look to the patient in front like that, like we saw in the African patient, there is a rim of sclera above and a rim of sclera below the cornea. So this means that the eye globe is pushed out. But like Dr. Almost better if we look from the side view. You see, you notice here the eye is really bulging, right? But a better thing is to do the ruler test. What does it mean? If you have a ruler or you have a pen, or even you can apply your index finger try to touch the superior orbital ridge with the cornea with the maxillary bone. If you do it on yourself, try to do it now. But of course, those of you who are wearing eyeglasses, remove them before doing. You will be able to touch the 3 points. But look here. Here, since the patient has exophthalmos, you can either touch the supraorbital ridge with the cornea or the cornea with the maxillary bone, but not the 3 points together. Is it clear? So this is the third way of doing it. Okay? And the second way, I mean. The third way is by doing this technique. You ask the patient to sit on a stool below your level. You stand behind the patient and you elevate her head slightly, and you look like that, tangentially, in the supraorbital plane. All right? So normally, you can see only the nose and the supraorbital ridge and the forehead. But if the patient has exophthalmos, like here, you will be able to appreciate that the eyeballs are bulging from underneath the supraorbital ridge, like the eyes of a frog. Is it clear? So this is the third way of examining for exophthalmos. And of course, if you want to quantitate, if you want to measure the progress or the improvement of exophthalmos, you just send the patient to our colleagues at the ophthalmology department. They have this exophthalmometer, this device here. It resembles the device that you put on when you are tested for having new eyeglasses, where the ophthalmologist puts the glasses, the lenses, I mean. But here, instead of putting lenses, there is a scale here. I hope you can appreciate it, like a ruler. And at the angle of this device here, okay, there is like a mirror. And you ask the patient to look straight ahead, and you check where the cornea can touch the reading of this ruler. Normally, in all of us, this protrusion of the eyeball is not more than 18 millimeters, 1.8 centimeters. If it is 21 millimeters or more, this means that there is exophthalmos. And of course, our colleagues at the ophthalmology department, they can quantitate exophthalmos in measurement into mild, moderate, and severe. Okay, is that clear? Any problems so far? And this is ophthalmoplegia, like I showed you in the video. You see this patient is trying to look upwards, but this eye is looking obviously upwards better than Can you hear me? I think I was cut off a bit. Can you hear me now?
Yes, we can hear you now.
What was the last thing you heard? I was telling you about ophthalmoplegia. Could you hear that? Huh?
No, we lost you there.
Okay.
Doctor.
Okay, so can you still see my slide in slideshow?
Yes.
Okay, so this patient is looking upwards. She has periorbital puffiness, as you can see in both eyes, but this eye looks up better than this eye. So this is normally both optic axes are parallel. Okay, both eyes look up the same degree, they look down to the same degree, and so on. But here, this eye looks up better than this one. And so if the patient is trying to look up and lateral, there will be diplopia. Okay, diplopia. And this is another patient having Graves' ophthalmopathy. There is obvious periorbital puffiness. There is obvious exophthalmos, and there is obvious conjunctival chemosis as well, here, particularly in the left eye. And you see here, she's looking straight ahead, but with this eye is looking down. So she has ophthalmoplegia. And when we did a CT on the orbits, this is an axial CT, this is front, this is back, this is right, this is left. Bone appears white because this is a type of X-ray. So this is the sphenoidal bone, right? And the rest of the skull bone. And this is the ethmoidal cribriform plate of ethmoid. And this is the nasal septum, the nasal cartilage. The white arrows point at the medial and lateral recti muscles. You will notice that they are bulky. Can you hear me again? I think my connection was lost for some seconds. Can you hear me again now? Huh?
Yes,
Now,
doctor.
yes.
Okay. Well, did you, until when, where did you hear? Until where? Did you hear my describing the CT of the orbit? Huh?
Can you say it again, doctor, please?
Okay. So this is a CT on the orbit. It's axial, cut at the level of the orbit like that, if you can see my picture. Bone appears white and soft tissue appears gray, and fat and air and CSF appear black. So this is the sphenoid bone. This is the cribriform plate of ethmoid. This is the nasal septum, the nasal cartilage, and this is the rest of the skull bone. And of course, these are the eye globes, the right and the left. You can see the lens, very nice. The vitreous appears grayish because it has a big water content, and the anterior chamber also appears. Can't hear me? Can you hear me? Can you hear me?
دلوقتي يا دكتور دلوقتي أيوة.
طيب. The vitreous appears grayish because it has a high water content. The anterior chamber also appears dark grayish in color because of the aqueous humor. This is the optic nerve, and the white arrows point at the medial and lateral recti muscles, which are bulky. Why are they bulky? Because they are infiltrated by lymphocytes, okay? And there is enlargement of or increase of the retroorbital fat, and there is also deposition of lymphocytes retroorbital. All these factors increase the intraorbital pressure and cause the exophthalmos in Graves' ophthalmopathy. Okay, is that clear? Any problems so far?
Yes, doctor.
Okay, now coming to thyroid ultrasound. This is a normal thyroid ultrasound. Okay, I don't know. Can you still hear me? I was cut off again. Can you still see my slides?
Now, yes.
Okay.
Now, yes, doctor.
Okay. So this is a thyroid ultrasound, a normal thyroid ultrasound. Let me show you the landmarks. Here, of course, the patient is lying on the back, on his or her back, and the neck is hyperextended. Okay. The landmark in the middle, the white area here, is the trachea. Tracheal rings appear white. Okay. And what is in front of the trachea is the isthmus of the thyroid. This is the right lobe, and this is the left lobe. Okay. So it is uniformly hyperechoic. Hyperechoic compared to the strap muscles. These are the strap muscles. They appear black in color. This is the sternocleidomastoid muscle. They appear like relatively black compared to the thyroid lobes. Okay, and this is the internal carotid artery here. All right. Now, again, so this is the trachea, the isthmus in front of it, trachea, isthmus, the right thyroid lobe, the strap muscles, sternocleidomastoid, and the rest of the sternohyoid and sternothyroid, okay? And this is the left lobe, okay? And this is the common carotid artery here, okay? And this is the inferior, the internal jugular vein, the internal jugular vein, and this is on the left side, this is the esophagus. You can appreciate that it has a wall, it has a thick wall, and if you look closely inside, there is a mucosa, and it will be even more evident if you ask the patient to swallow while you are looking at this structure. You will notice that saliva will come inside. It will contract on swallowing. And of course, in all ultrasound pictures, there must be this key to show you whether it is a transverse cut or a longitudinal cut. Okay, again, this is the trachea, the isthmus, the right lobe, the left lobe, the carotid artery, the jugular vein, the esophagus. Okay, and here they have zoomed into the right thyroid lobe only. All of these are normal because it is hyperechoic, yani whiter than compared to the strap muscles. Okay, okay, and so here you can see the typical sonographic features of Graves' disease. You can appreciate that the isthmus is enlarged. They can actually, on ultrasound, they can measure the thickness in millimeters, and the lobes are as well enlarged, okay? But so it is a diffusely abnormal appearing thyroid gland. It is enlarged, heterogeneous. You see the echogenicity is not all the same. Some hyperechoic areas like it should normally be, but there are some hypoechoic areas as well. If you do the Doppler or the duplex study, you will find diffusely increased vascularity. Why does it appear mosaico in color? Because of the turbulent blood flow. Some blood is flowing towards the transducer, which appears red, while some other blood is flowing away from the transducer, which appears blue. Okay, this picture is called thyroid inferno. And when we see this on Doppler study, this is diagnostic for Graves' disease. Okay. Now this is the thyroid ultrasound in subacute thyroiditis. Here you will notice that the thyroid gland is enlarged with a heterogeneous echo texture. You notice some parts are hyperechoic compared to the strap muscles, while some parts are hypoechoic. And if you do a Doppler study on the right thyroid lobe, you will notice reduced vascular flow. Okay, reduced. It's reduced. Right. Now, this is the thyroid ultrasound in Hashimoto's thyroiditis. The other term for Hashimoto's thyroiditis, if you remember, is chronic lymphocytic thyroiditis. Here, you will notice the thyroid is hypoechoic with a coarse micronodular. It appears as if there are some micronodules, okay? Echo texture of the gland. These are not nodules, these are pseudo PSEUDO false nodules, okay? Or micronodular echo texture, all right? Again, another, this is the transverse view, and this is the longitudinal view, okay? In the, here is the isthmus. You notice it's enlarged. This is the longitudinal view, this is the right, and this is the left lobe. Okay, both of them show hypoechoic. They are similar in echogenicity to the strap muscles, almost, with micronodularities. Okay, is it clear? So the dominant feature is a diffuse hypoechogenicity. This here, see, it's similar to the strap muscles. And it's seen as black holes, indicating absence of thyroid tissue. There is some scarring, the white areas, okay? And there is decreased vascularity if you do the Doppler study with architectural damage in an overall enlarged thyroid gland, okay? So far, any problems? Again, here,
It's good
the thyroid.
so far.
Okay, the thyroid gland is shrunken because at some time point, you see in Hashimoto, the goiter tends to shrink when it goes more towards the atrophic thyroiditis. So here it appears a bit shrunken with scarred and shriveled. The white patches are fibrous tissue, pseudonodules. You see, these areas are pseudo. PSEUDO means, it's a Greek word meaning false, and scattered fibrous bands in a small gland. This is the final stage of Hashimoto's thyroiditis, where the patient has hypothyroidism. All right? Any problems? Now coming to the difficult part. I hope it's not so difficult. Thyroid nodules. Unfortunately, I wasn't able to attend the scientific meeting on thyroid nodules, so I don't know what exactly you have been told, so let me revise. Actually, we have something called TIRADS classification. This is the classification according to the American College of Radiologists. It depends on, it gives several scores to the thyroid nodule, depending on the composition, the echogenicity, the shape, the margin, and echogenic foci, right? So if the composition, if it is cystic or almost completely cystic, it gets 0 points. Or if it's spongiform, it gets 0 points as well. If it's a mixed cystic and solid, it gets 1 point as regards the composition. If it's solid or almost completely solid, it gets 2 points, okay? According to the echogenicity, if it is anechoic, there are no echoes inside, so in the nodule, it gets 0 points. If it is hyperechoic or isoechoic, it gets 1 point. But if it is hypoechoic, it gets 2 points. If it is very much hypoechoic or almost black, it gets 3 points. Depending on the shape, if it is wider than taller, it gets 0 points. If it is taller than wide, it gets 3 points. Depending on the margins, if it has smooth or ill-defined margins, it gets 0 points. If it has a lobulated or irregular margin, it gets 2 points. If there is extra thyroidal extension, it gets 3 points. And depending on presence of echogenic foci in the nodule, if there are none or large comet tail artifacts, like I'm going to show you in the pictures in a while, it gets 0 points. If there are macro calcifications, it gets 1 point. If there are peripheral rim calcifications, it gets 2 points. If there are punctate echogenic foci, it gets 3 points, okay? So depending on, they add all these points together. If the total is 0 points, it's a TIRAD 1. Most probably it is benign, so not indicated for fine needle aspiration. If it gets 2 points, then it is TIRAD 2. And again, it's not suspicious. Again, no fine needle aspiration should be done. If it gets 3 points, then it is mildly suspicious or TIRAD 3. And you do a fine needle aspiration if the size of the nodule is 2.5 centimeters or more, and you follow up if the size is 1.5 centimeters or more, okay? If it gets 4 to 6 points, then it is moderately suspicious or TIRAD 4. And here you do a fine needle aspiration if the nodule size is 1.5 centimeters in size or more, and you follow it up if the size is 1 centimeters or more. If the nodule gets 7 points or more, then it is highly suspicious or TIRAD 5. And you do a fine needle aspiration if the size of the nodule is 1 centimeter or more, and you follow it up if the size is 0.5 centimeters or more. Did you hear this classification before? Huh? I don't know if you know it or not. Okay, so I hope it's not going to be very difficult for you to understand. Let me show you these patterns that I told you about. These are the different patterns, you see. A solid cystic nodule. Here the solid component is more, the solid component is even more, and it's isoechoic. And here there is a nodule that appears to be somewhat hypoechoic, but it's wider than taller. This nodule appears to be taller than wider, okay? And here there is an ill-defined margin with some extra thyroidal enlargement. Okay, so these are the sonographic features again, according to the TIRADS classification that like I just mentioned. I'm not going to repeat. And here, let me apply that. This is a nodule in the left side of the isthmus. Here is the trachea. This is the right thyroid lobe, and here is the left thyroid lobe. So this is the left side of the isthmus. You can appreciate there is a nodule here, right? The lady, the patient is 61-year-old. Here the nodule, the nodule size is 0.98, less than 1 centimeter by 0.72. Okay, so let me show you. This is a spongiform nodule. It appears like a sponge, you see, and the size is 0.9 centimeters. Again, the lady is 59 years old. Here, more than 50% of the nodule is composed of small cystic spaces, the black areas. So the nodule received 0 points for composition because it's spongiform, and so it was designated as TIRADS 1. Clear? Now here, and this is a 40-year-old woman having a benign, mixed, cystic, the black area, solid nodule. Okay, there is 1 point for being isoechoic, has the same echogenicity like the thyroid lobe, okay? And it is distributed around the periphery. So the nodule received 2 points, okay? So it becomes thyroid 2. Okay, is it clear? One point for being mixed cystic and solid, and 1 point for being isoechoic for the solid component. And here this is a sagittal longitudinal meaning, ultrasound of 4.6, this one, a very big 4.6 benign colloid nodule in a 65-year-old woman. It was classified as being solid, so the composition score of 2, it's solid, you can see. Although small cystic components were also present, the black spots, okay? With 1 more point for isoechogenicity, the same echogenicity as the thyroid lobe, and none other categories. So it has 2 plus 1 is 3. So it goes into thyroid 3, okay? And here is a benign follicular thyroid nodule, this one, all this one, with smooth margins in a 50-year-old woman, okay? So it was assigned 2 points for having a solid composition and 1 point for being isoechoic, the same echogenicity like the thyroid isthmus, okay, of it, with a total of 3 points. Again, thyroid 3. Here, this is a mixed cystic and solid papillary thyroid cancer. Notice here, this is a 39-year-old man. He's a male. He has a lobulated solid mural component, okay? And punctate echogenic foci. You see the small white dots, punctate. So the nodule received 1 point for composition because it's solid, 1 for being isoechoic, the same echogenicity, and 3 points for the punctate echogenic foci. So a total of what? 3 plus 2 means 5. Thyroid 4. Can you follow me? Is it difficult what I'm saying? Huh? Am I going too fast? This is a transverse thyroid ultrasound. This is the isthmus. The trachea. This is the isthmus. This is the right thyroid lobe, the left thyroid lobe. And here is a markedly hypoechoic. It appears black. If you compare it to the thyroid isthmus and thyroid lobes, it appears black. So it's hypoechoic. This is a 24-year-old woman. The nodule received 2 points for being solid and 3 points for being markedly hypoechoic, bringing it to 5 points, or thyroids 4 again. Okay? And this is another nodule that appears taller than white. It turns out to be a papillary cancer. Okay? This is a 47-year-old man. So for the shape, it's taller than white, so it got 3 points for that. The nodule warranted 2 points for being solid and 1 point for being isoechoic to the isthmus, okay? And 3 points for the numerous punctate echogenic foci. So 3 plus 3 is 6, plus 2 is 8, plus 1 is 9. 9 points, so it's highly suspicious. Thyroid 5. Is it clear? Here again, there is thyroid carcinoma with an irregular margin. You can notice the arrows here. Okay, on this panel, this is the sagittal or the longitudinal picture, ultrasound picture of a 2.2 centimeter carcinoma, all of this, okay, in a 61-year-old man, which shows a lobulated margin, you see, and giving it a 2 points, and it has also 2 points for being solid, okay, and 2 for hypoechogenicity compared to the thyroid. It appears black, more black than the relevant thyroid lobe. And so it has a total of 6 points. So it's thyroid 4. And here is a sagittal sonogram of a 1.2 centimeter carcinoma with an irregular margin again, speculated, okay? This is a 39-year-old lady. And so in addition to the 2 points for the irregular margin, the nodule was also assigned 2 points for being solid and 3 points for the very low echogenicity compared to the remaining thyroid lobe, and 3 points for the punctate echogenic foci. So the total is 10 points. Thyroid 5. Do you follow me? Is it difficult? Can you appreciate what I'm saying? Yes, can you hear me?
Doctor.
Okay. And this is a papillary carcinoma bulging on the thyroid border. You see, this is the trachea, the isthmus, the left thyroid lobe. You notice here it's irregular. The surface is irregular, so the nodule, all of this, is bulging through the anterior surface of the thyroid. But there was, at surgery, they didn't demonstrate any invasion. The nodule received 2 points for being solid, 2 points for being hypoechogenic compared to the remaining thyroid lobe, 3 points for being taller than white, okay, and 2 points for the lobulated margin. Okay, so the total was 9. Again, TI-RADS 5. Okay. And here are the comet tail artifacts that I was telling you about. You know what a comet is? المذنب, a comet, this one. Can you see it? It's like a star having a tail. So these are punctate echogenic foci in a papillary carcinoma, this one, in a 54-year-old woman. So in addition to the 3 points for punctate echogenic foci or the comet tail artifacts, the nodule was assigned also 2 points for being solid in composition and 2 points, another 2 points for being hypoechoic compared to the remaining thyroid lobe, and 2 for a lobulated margin. You see the margin. And so the total is 9 with a TI-RAD 5. Okay? So this is the complete report. This is how a complete ultrasound report, ultrasound report on the thyroid should look like. It should mention the nodule number, the location, left upper, the composition, solid or cystic or mixed, echogenic, iso, hypo, or hyperechoic, the shape, whether wider than tall, the margin, whether it's smooth or irregular, and echogenic foci, whether there are peripheral calcifications, macro calcifications, or comet tail, punctate echogenic foci, as well as the size. And finally, it should mention the total points it has received together with the TI-RADS category. Of course, yani, we don't see such an organized ultrasound report all the time, unfortunately, but this is the way it should be. Okay, is it clear? Now coming to the thyroid scintigraphy. Thyroid scintigraphy is imaging of the thyroid using radioactive iodine or radioactive technetium. Okay, so the normal thyroid looks like that. It has a normal size and it takes the radioactive material evenly. They can calculate the percentage of uptake. Okay, in thyroiditis, there is markedly reduced uptake of radioactive iodine. Why? Because the itis, the inflammation, has affected the functions, all the functions of the thyroid gland, including radioactive iodine trapping. While in Graves' disease, there is a uniform increased diffuse increase of radioactive activity, okay? While in toxic multinodular goiter, only the toxic nodules are avid to the radioactive material, while the rest of the thyroid is suppressed, and you can even appreciate some if there are some cystic degenerations in some of the nodules, you can also appreciate some cold nodules, like here. In a single nodule, you can very much appreciate if you have a cold nodule, which is most probably cystic on ultrasound, or a hot nodule. A hot nodule is a functioning nodule. It can be a single, a solid toxic nodule, or sometimes it may be also malignant, okay? So this is thyroid scintigraphy. Okay, so this concludes the part that I wanted to discuss with you last Monday. If you want to continue, I can revise with you the parathyroid diseases as well. But first, let us take if you want. But if you don't want, then we'll call it a day. You tell me. You want to continue, or are you tired? You tell me. Yes, Dr. Nadine, you have raised your hand. Is there something you want to tell me, Dr. Nadine? Dr. Nadine, I cannot hear you.
I think
Sorry?
I think
I
we
don't.
should continue.
Okay, in that case, I need to go drink something. Let's take a 10-minute break and then we will continue. Okay? Do you agree?
تمام يا دكتور.
Okay.
Okay, so please write in the group, Dr. Sama, because somebody may want to join us. Okay?
تمام.
We will resume at 10 p.m. inshallah. Okay? Thank you.
تمام.
Thank you. Are you back? Can you hear me?
Yes, doctor.
Okay. Only 4 remaining? Only 4 students? Where's the rest? Somebody else coming? Somebody else coming? Okay, I will not share the video recording. I think the other students are relying on watching the video recording. I'm not going to share it. غايب ملوش نايب. Okay. So let me share my slides with you. Can you see my slides?
Yes, doctor.
Yes, doctor.
Okay. So regarding the intended learning outcomes of this session, by the end of this session, you will be able to list the symptoms and signs of hyperthyroidism. You're going to be able to understand the various imaging modalities in hyperthyroidism, namely plain X-rays, ultrasound, CT, MRI, and technetium sestamibi scan. And you are going to be able to detect the clinical presentations of hypoparathyroidism, acute and chronic. And you're going to be able to list the signs of hypoparathyroidism. You're going to be able to enumerate the investigations of hypoparathyroidism. And you're going to understand conditions mimicking hypoparathyroidism. Mimicking means that are similar to hypoparathyroidism, namely pseudo-hypoparathyroidism and pseudo-hypoparathyroidism. Okay? So let me start by hyperparathyroidism. These are, in general, the clinical manifestations that you can appreciate in hyperparathyroidism. Let me, something covering my slides. Yeah, in lobby. Okay. Anyway, so the patient can present with general aches and pains, with proximal myopathy, with renal calculi or nephrocalcinosis, with hypertension, with constipation and abdominal pain, even chronic pancreatitis and calculi, dyspepsia, pseudo-gout and chondrocalcinosis. Yes. Yes.
معلش يا دكتور، في ناس عاوزة تدخل بس مستنيين حضرتك تابروف.
ما أنا عملت approval. I admitted already. Nobody is in the lobby. Nobody is in the lobby.
تمام خلاص. نادين دخلت خلاص. تمام.
Okay. خلاص. So this is why when I tell you a specific time, you log in that time, because otherwise this is disturbing, you see. And you are interrupting my thoughts now. Anyway. I forgot where I was. I was telling you, the patient presents with general aches and pains, with myopathy, proximal myopathy, again, proximal. Okay, proximal. Remember, like in hypothyroidism and in hyperthyroidism and in acromegaly. Renal calculi or recurrent renal stones or nephrocalcinosis. They have polyuria, polydipsia. They have hypertension. They have pseudogout and chondrocalcinosis. They have bone cysts and brown tumors and maybe even pathological fractures. They can have dyspepsia, constipation, abdominal pain, chronic pancreatitis even, and calculi. They can have anorexia, nausea, vomiting, excessive thirst. They have corneal calcifications, and they have osteoclastomas of the jaw. This is particularly seen in secondary hyperparathyroidism. And if it's part of multiple endocrine neoplasia type 1, there may be also evidence of pituitary tumor, or if it is a part of multiple endocrine neoplasia type 2A, there may be also affection of the thyroid in the form of medullary thyroid carcinoma. Okay, so this is This is a summary of all the different complaints and signs you may see in primary hyperparathyroidism. This is band keratopathy. You see, this is the cornea, and here is 9 o'clock, here's 3 o'clock, okay? You can appreciate there is like a white band covering the cornea. This is actually an advanced case of band keratopathy, but early, if you want to examine your patient with primary hyperparathyroidism early, you ask the colleagues at the ophthalmology department to examine with a slit lamp, you see? So this is the cornea of the patient, and the illuminated arc is the light of the slit lamp. You will be able to notice there are specks of calcifications inside the cornea. But if you look at them with your naked eye, you won't be able to see them. So, okay, so this is early band keratopathy. All right. Now coming to the investigations in hyperparathyroidism, radiology. All right. And of course, you know that in endocrinology in general, we do first the lab. So here I have omitted the lab, and I'm going to discuss right away the radiology. We can do plain X-ray. Plain X-rays, I will show you several of them, that show generalized osteopenia up to osteoporosis, all right? There will be loss of lamina dura of the teeth. I will show you how it looks like. There will be subperiosteal bone erosions. You may see bone cysts and brown tumors. You may see osteitis fibrosa cystica, particularly in secondary hyperparathyroidism in patients with chronic renal failure. And you may see also calcification of soft tissues. So let me show you some of this imaging. The plain X-rays. Slides are stuck. Yes, so this is an intraoral periapical radiograph, the one you do, the panoramic radiograph you do when you go to the dentist, okay? But there is a close-up on some teeth. Why? To show you the normal lamina dura. These are the molar teeth, I think, or the premolars. If you look closely, the bone has nice trabeculae, right? The bone of the mandible has nice trabeculae. If you look closely, there is a white line here, a white line there, okay? A white line here, and a white line there. This is the normal lamina dura. But here, this is an intraoral periapical radiograph in a patient with primary hyperparathyroidism. You will notice that the bone trabeculae, they are lost, you see, as the bone appears black, as if there is no bone any longer. And there is complete loss of the lamina dura. This white line is absent. Can you appreciate that? There is no white line any longer. Can you appreciate that? So this is what it means when I say loss of lamina dura. And here you can notice this is a plain X-ray of the left hand of a patient with hyperparathyroidism, showing what? Subperiosteal bone resorption here with acro-osteolysis. If you look closely here, the radial aspect of the middle phalanx appears as if the bone is eroded. So this is the subperiosteal bone resorption, okay? But here, if you look closely at the tufts, remember the tufts? The tufts of the terminal phalanges, they appear as if they are eroded. So this is acro-osteolysis, okay? And this is the right hand of the same patient showing the phalangeal, the subperiosteal bone resorption is more extensive here, affecting the index finger and the middle finger, okay? And the phalangeal tuft resorption, or the acro-osteolysis, is even more extensive. It appears until the little finger, okay? Can you see it? Can you appreciate it? And this is subperiosteal bone resorption, which is extensive, but in a child. How do I know that this is a child with hyperparathyroidism? Because the epiphyses are still open, okay? Here you can still see it is extensive. The radial and the ulnar surfaces of the middle phalanx are eroded, okay? Can you appreciate the findings? This is subperiosteal bone resorption before treatment, and this is after treatment. As if the periosteum appears like a white line, a nicely drawn white line. All right? Here you can appreciate it is eroded. Can you appreciate that? Now, this is a plain X-ray of the skull in lateral view showing the salt and pepper skull. The salt is the white areas and the pepper are the black areas. The black areas are obviously the areas where there is osteolysis or bone erosion. So this is a normal skull, how it looks like in all of us. And this is the salt and pepper skull. I think the difference is very evident, right? So now let me tell you, this is a plain X-ray of the right hand of a patient with hyperparathyroidism showing, in addition to extensive subperiosteal bone resorption in the thumb, in the index, in the middle finger, very extensive, the ring and the little fingers. There is also phalangeal tuft resorption, which is also extensive in all fingers, but there is osteopenia, and here the arrow points at this brown tumor. What is a brown tumor? Or what is the difference between a brown tumor and bone cysts? Here you can see this is a plain X-ray of the left hand of a patient with hyperparathyroidism showing multiple bone cysts here, 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 and there. It appears as if these are areas devoid of bone. كأن جايبين مقورة كده ومقورين العظم. Okay? Now, this is another typical area for brown tumor. Here, this is a plain X-ray on the left hip joint and pelvis showing a brown tumor in the inferior obturator ramus of the pelvis. This is it appears like an expanded bony lesion with eggshell appearance. All right. Now, this is a plain X-ray of the knee. We don't know whether it's the right or the left knee. It's not specified. Of a patient in close-up showing, this is the femur, this is the tibia, the tibial condyles, okay? Normally, the cartilage doesn't appear on plain X-ray. It appears black. But here, if you look closely, you will appreciate a white line here, some white lines here and there. These are calcifications in the cartilage inside the knee, chondrocalcinosis, right? And this is a plain X-ray on the right hip joint of a patient with secondary hyperparathyroidism. This is the head of the femur, the neck, the greater trochanter, the lesser trochanter. Of course, they have zoomed in on the neck of the femur, and this is the acetabulum, showing what? The arrow points at something that looks like a fissure or like a fracture, but this is not a fissure fracture. These are Looser's zones. The typical X-ray findings in osteomalacia in secondary hyperparathyroidism. Okay? And this is a plain X-ray of the spine, the thoracolumbar spine in lateral view in a patient with secondary hyperparathyroidism showing osteosclerosis. What does it mean? It gives you the rugged jersey spine. What is that? You notice here the vertebral bodies, they appear whiter than usual, okay? While in between the vertebral bodies, there are the intervertebral discs, which are cartilage and fibrous tissue, so they appear black. So it gives the appearance of a striped jersey. You know, in the past, soccer players or rugby players or hockey players, whatever, they used to wear jerseys that were striped like that, white and yellow, white and black, black and red, red and white, and so on. Not like nowadays, they wear jerseys with commercials for Vodafone or Coca-Cola and so on. So the appearance of this spine in osteosclerosis is similar to the rugged jersey of those players. So this is why they called it rugged jersey spine. Is that clear? Any problems so far? Can you still hear me?
Yes,
okay.
doctor.
Okay. You may have noticed that watching a patient with chronic renal failure and secondary hyperthyroidism walk. You notice that they have a waddling gait, right? You may have noticed that. Why is that? For two reasons. The first and foremost important reason is they have proximal muscle weakness of the glutei and the hip joint, the hip muscles, I mean, the hip joint muscles, okay? So this is why they have this waddling gait. But an additional feature is because they have a widened sacroiliac joint, you see? So this is a plain X-ray of the lumbosacral spine, showing normally the sacroiliac joint should be just in line, but here you notice it is widened, okay? So this gives additional instability to the pelvis, leading to adding to this waddling gait, okay? Now, I told you earlier that they may develop pathological fracture. What does it mean when I say pathological fracture? This is a fracture due to very minimal or very mild trauma. For example, this patient will tell you he will come or she will come with pain and a limping gait in the right hip joint. Okay, you will ask her, did you fall down? No. Type, what happened? She will tell you, I just tripped over the map, over the mattress, okay, over the, I mean the مشاية يعني the rug, over the tip of the rug. This is very minimal trauma. In spite of that, she developed this fracture. This is the acetabulum, okay? This is the head of the femur. Where is the neck? It is fractured and it's compressed. This is the greater trochanter and this is the lesser trochanter. And you can see that the bone density appears to be very reduced, very much reduced, okay? So this is a pathological fracture in the right neck of the femur, okay? And this is a plain X-ray of the left femur. The femur is one of the large bones in the body. In order to be fractured like that, it needs strong trauma, like a car accident, road traffic accident, what fall from a height. But here the patient tells you, I just tripped over the tip of the rug. Is that my heavy trauma? No, it's very minimal trauma. Why? Because here you see there is a brown tumor distally with if you look closely inside it, there is endosteal scalloping. This is a typical brown tumor. There has been another brown tumor more proximally, and the patient was unfortunate enough to have a pathological fracture through this proximal brown tumor. Okay, so this is after 9 months after healing. It shows fusion of the proximal, the pathological fracture with callus. This is how callus looks like on plain X-ray, but the distal brown tumor is still there. So if the patient is really unlucky, he or she will develop another pathological fracture through this brown tumor, right? So here is the brown tumor and the pathological fracture before and after healing. Okay, is that clear? Okay, now coming to nephrocalcinosis. Nephro is kidney, calcinosis is calcium deposition. If you look closely, this is a plain X-ray in PA view of the kidneys. This is the spine. This is the last rib on the left side, and this is the last rib on the right side. And here is the renal angle, okay? The renal shadow can be seen here. And here is the renal angle. The other renal shadow can be seen here. Look at the white specks. These white specks, ignore this one. Look at the white specks. These are calcifications inside the kidney tissue. Okay, now let us look at ultrasound in hyperparathyroidism. So far, any problems with the place? Huh? Any problems? Can you still hear me?
So far, it's good.
Okay. Now, let me show you how nephrocalcinosis looks like on ultrasound of the kidneys. This is front, this is back, okay? Why does the ultrasound picture look as if it's conical in shape? Because of the transducer. The beams are like rays, okay? The rays are dispersed like that. The rays, some of the rays, they pass through some of the rays are reflected, and some of the rays, if they encounter any calcification or any stone, they cast an acoustic shadow. So this is the diaphragm, this is the liver, this is a longitudinally cut kidney, right? This is the cortex, appears somewhat black in color. And this is the medulla. You notice the medulla here appears very white. Why? Because, and the triangular areas here, these are the pyramids, okay? These are hyperechoic foci in the pyramids casting a posterior acoustic shadow. What is an acoustic shadow? Remember I told you the ultrasound rays, they come from the anterior side of the abdomen and they go through till the back, the posterior aspect of the posterior abdominal wall. If they encounter any obstacle, like the calcified pyramids, this appears like a shadow. Imagine you are going in the middle of summer in the sun. The sun is very, very hot, so you're wearing an umbrella. You're carrying an umbrella. Under the umbrella, there will be a shadow, right? So it's the same. The ultrasound rays will encounter the calcifications, so they will cast an acoustic shadow behind, okay? And this is another ultrasound picture. This is the right kidney. Here it shows that, you see here, it shows that it is transversely cut. So this is the diaphragm, this is the liver, the portal tracts, and this is the right kidney. And inside, this is the cortex, the medulla, the pyramids are all calcified, okay? How? This is another picture of nephrocalcinosis, transabdominal ultrasound. This is the kidney, okay? Here, the pyramidal shapes, the pyramids of the kidney are very, as if they are drawn with a pencil, okay? They appear very white in color, casting a very dark posterior acoustic shadow, all right? Okay, so this is how nephrocalcinosis looks like on ultrasound. How do renal stones look like? They look similar, but the place is different. Here, remember, the nephrocalcinosis affects the pyramids of the kidney. The pyramid is where, imagine if you can see my hand, this is the collecting system, the calyces. Inside, in between the calyces, are parts of the kidney forming the pyramids. So this is the site of deposition of calcium in nephrocalcinosis. But in renal stone formation, actually, the renal stone itself is inside the calyces, inside here, okay? Inside, depends where it is. So they are lighter in color, they are more dense. This is one kidney and this is the other kidney, and they cast a darker acoustic shadow. And in that context, in hyperparathyroidism, the patient will complain of recurrent multiple renal stones, like you can see here on this ultrasound. Now, this is neck ultrasound. Remember the thyroid ultrasound that I showed you earlier? The landmark is the same. Here is the trachea. This is the isthmus of the thyroid. This is the right lobe of the thyroid, of course, in close up. But here the arrows point at a hypoechoic inhomogeneous lesion, which represents one of the parathyroid glands. Please note that normally the normal parathyroid glands are invisible on thyroid ultrasound, on neck ultrasound. Once they are visualized, this means that they are hyperplastic, okay? This is a very important piece of information. This is another ultrasound. You see, here is the trachea, the isthmus, the left thyroid lobe, and all this is the left parathyroid adenoma. It's hypoechoic. It appears darker than the relevant thyroid lobe. Again, this is another neck ultrasound. This is the trachea, the isthmus. This is the left lobe of the thyroid. This is the carotid artery. And here behind, posterior medial to the left lobe, is the hypoechoic enlarged parathyroid gland. Is it clear? Now coming to CT in hyperparathyroidism. Actually, when there is a brown tumor of the jaw, I didn't bring a picture of a patient actually with a brown tumor, but the patient will present with a painless swelling, usually of the lower jaw. One time we saw a patient coming with a bony swelling here in the near the nose, in the maxillary bone. But what is more common is a swollen, very much swollen, asymmetrical jaw. Okay, so if you bring the patient, if you ask the patient to do a CT skull coronal view, as I mentioned earlier, bone appears white. So this is the middle cranial fossa, the sphenoidal bone. These are the orbits. Okay, the nasal septum, the nasal turbinates. Okay, the nasal cavity containing air. This is why it appears black. Okay, and here you notice the teeth are distorted, and the mandible is enlarged by a large bony tumor. How can we say it is bony? Because you can see septi, as if there is eggshell formation. Yeah, there is bone resorption and attempts at new bone formation, and this is why it appears like that. And of course, this bone, it's swollen from the outside, and it can be also appreciated from the floor of the mouth of the patient. So this is a brown tumor of the jaw, or the other name is an osteoclastoma of the jaw. Okay, now coming to an axial CT of the neck. Again, this is front, anterior, this is posterior, this is right, this is left. Bone appears white, so this is the cervical vertebra. Okay, and this is the trachea. Air appears black. The isthmus, the right thyroid lobe, the left thyroid lobe, and here this A points at a parathyroid adenoma in the right perithyroidal region. Okay, now this enhanced CT chest, enhanced means that they have given intravenous contrast to the patient. This is axial. It's cut like that, like the previous neck CT. Also, it was axial, cut like that. Okay. Now here you can see this is anterior, this is posterior, this is right, this is left. The vertebra appears white, and these are the ribs on the right side, the ribs on the left side, part of the scapula on the right, part of the scapula on the left. Okay. Now this is the ascending aorta, the aortic arch, and the descending thoracic aorta. Why does it appear so white? Because they have administered intravenous contrast, and of course the lungs, they appear black because they contain air. This is the right lung, the left lung. And here you see the arrow is pointing at a lesion anterior to the arch of aorta. It's present in the superior mediastinum, in the anterior part of the superior mediastinum. This is actually a frequent location for an ectopic parathyroid adenoma. You know that normally there are 4 parathyroid glands. They are located at the posterior aspect of the thyroid lobes, okay, in the neck. But there are many ectopic sites for parathyroid adenomas. Okay, how do we detect them? For one thing, you can use enhanced CT chest like that, or you can use also an MRI. Like here, this is an unenhanced axial T1 weighted MRI. Axial, it's cut like that again. Okay. Why do we say it's T1 weighted? Because here, this is the vertebra. Inside, you can see the spinal cord, and the CSF appears black. The same principle like in the MRI of the pituitary. Okay. And here you can see the trachea. It's black because it contains air. The right lung, the left lung, thyroid. Here we are at a lower level. Actually, we are at the level of the superior mediastinum again, where you can visualize the trachea and the esophagus, and in between them, in the paraesophageal, tracheo-esophageal tract, there is this lesion. In T1 weighted images, it appears black like that, somewhat grayish black, and in T2 weighted images, remember the CSF has become white now, okay, and the ectopic adenoma appears iso-intense. Okay, is it clear? So this is another way to see or to detect an ectopic parathyroid adenoma. But actually, the best method, or one of the best methods too, because nowadays there is also the 4D CT with contrast. I haven't brought you any pictures of that because it's a bit complicated to explain and a bit complicated. We don't usually do it very often, yani. The sestamibi scan is in hyperparathyroidism is the scan using radioactive technetium. You do a radioactive, it's similar to what I have shown you earlier regarding the thyroid scan, right? Thyroid scintigraphy. But here you do a delayed image after 3 hours. Early, the salivary glands, all of the salivary glands and the thyroid and the parathyroid glands, they take up technetium, okay? But on delayed films like here, you notice the radioactivity has declined from the salivary glands and from the thyroid, but it's still very obvious in the inferior pole of the left lobe of the thyroid gland. So this means that this is a parathyroid adenoma, a left inferior parathyroid adenoma. The technetium sestamibi scan can appear colored like that, or it can appear black and white like that. Here you can notice this is the very early scan, the somewhat delayed, more delayed scan. After 3 hours, everything fades away except the radioactive uptake in the adenoma, in the parathyroid adenoma exclusively. Okay, so the previous image of this enhanced CT, you see here, there is, when they sent the patient to do a technetium-99 sestamibi scan, there is nothing in the neck, nothing visualized in the neck. This means that this patient had an ectopic parathyroid adenoma here in the superior mediastinum, okay? And when they did surgery, it was proven that this was an ectopic parathyroid adenoma. So in order to detect ectopic parathyroid adenomas, you can either do an enhanced CT chest with contrast, or better technetium-99 sestamibi scan. Okay? Any problems so far? Huh? Any problems? Okay, now coming to hypoparathyroidism. There are two clinical types of hypoparathyroidism. The acute one, which presents with overt tetany, carpopedal spasm, and the patient may even have stridor with laryngeal spasm, okay? A long time ago, when I was still an assistant lecturer, we had a patient. He was a male 45-year-old patient. He was a heavy smoker, and he had chronic bronchitis and he came presenting with acute exacerbation of his chronic bronchitis, okay, type. But he was bilaterally blind because he had bilateral cataracts, and he had a tracheostomy tube in place. We were wondering what happened to him. Why does he have a tracheostomy tube in place? So we asked him, what happened to you? He told us, I suffocated one day. I suffocated, so they brought me to ER, and there they saved my life by inserting a tracheostomy tube, and it was left ever since. Nobody bothered to try and search why he had stridor and suffocation. When we were examining the patient while measuring the blood pressure, he developed Trousseau sign. What is that? Trousseau sign is positive. And Schwastek sign was also positive. Oh my God, this patient has hypocalcemia. And actually, we checked the serum calcium level. It was very low, like 4 or something. And the phosphorus was high, and the PTH was very low. So the actual cause behind the patient's suffocation was that he had developed acute hypoparathyroidism, and it was life-saving for him to put a tracheostomy tube, but they never bothered to investigate. Okay. And we treated the patient. We gave him intravenous calcium gluconate infusion until his calcium level returned almost back to normal. Then we gave him oral calcium and vitamin D. And then we sent him, after his chest condition was controlled, we sent him to ophthalmology. He had cataract extraction in one eye, so he could see again. 1 month later, he did the cataract surgery in the other eye, and he was very happy. He could see again. Okay? So always take the patient in a holistic view. خلاص? But of course, it was life-saving to insert a tracheostomy tube, but you should have looked for the reason why he developed suffocation, okay, or stridor. Now, the chronic hypoparathyroidism is characterized by latent tetany, latent, it is hidden, and it may be also associated with some ectodermal and CNS changes. But nowadays, actually, I haven't seen many cases of acute hypoparathyroidism. We see more the latent tetany types, okay? Now, in the clinical manifestations in acute hypoparathyroidism include paresthesia, or abnormal sensation and numbness around the mouth and in the hands and feet, in the extremities, muscle spasms, especially in the hands and feet, what produce the carpopedal spasm, okay? Spasm of the laryngeal muscles, like what happened to our patient, which lead to respiratory dysfunction, stridor, and death. And the patient may even convulse, tonic-clonic spasm, which may lead to convulsions. Now, if you take proper history from the patient or the patient's relatives, you will be able to distinguish between convulsions of grand mal epilepsy, which is a neurological disorder, and the epileptiform convulsions of tetany, okay, or acute hypoparathyroidism. Can anybody tell me how? What is the difference? This is very important. Just by history taking, you can distinguish between both. Can somebody tell me how? Huh? Sorry? I don't hear you. Who said what? Sorry?
There is no loss of consciousness.
There is no
Yes. Okay. What else?
tongue biting.
There is no tongue biting. I mean, in the epileptiform convulsions of acute hypoparathyroidism, the patient may not lose consciousness. First of all, there may be no aura. In grand mal epilepsy, there is usually an aura, right? The patient feels that an attack is coming. And then during the attack, the patient with grand mal epilepsy loses consciousness completely, and he may be even incontinent. Okay, he or she, that is, he may even bite the tongue. He may injure himself if he falls, for instance, on the rails of the tram. He may cut his forehead or something like that. Okay, but usually in acute hypoparathyroidism, no, the patient is conscious, like you mentioned, and he can protect himself. And in grand mal epilepsy, after the attack is over, the patient passes into deep sleep. But after the epileptiform convulsion of acute hypoparathyroidism is over, the patient usually is conscious and he doesn't fall into deep sleep, and he or she, they can tell you, I could hear you, you brought me some water to put on my face, you brought me some eau de cologne to sniff, and this person called the ambulance. Yani, this means that the patient didn't actually lose consciousness. Okay, is that clear? So it's very obvious. Of course, you can objectively, you can do an EEG and in electroencephalography. In that case, you will find the abnormal electric activity in grand mal epilepsy, but there isn't anything like that in acute hypoparathyroidism. Okay? Type. What about chronic hypoparathyroidism? I mentioned it is a latent tetany, so you could only see it by doing special signs like Schwostek's and Trousseau's signs. I'm going to show you in a minute. And the ectodermal changes include dry, scaly skin, similar to that found in primary hypothyroidism, brittle and sparse hair, again similar to that in primary hypothyroidism, but there are ridged nails with white patches and the lens opacities, like we could see in the patient I told you about, with abnormalities of the teeth. These are the ectodermal changes. Regarding the CNS changes, there are some mental abnormalities like epileptiform attacks and papilledema. Don't forget papilledema, okay? So in order to elicit Schwastek sign, you ask the patient to relax, to open the mouth a bit, and you tap in front of the tragus or between the tragus of the ear and the angle of the mouth. Okay. Normally in all of us, nothing happens. But if the patient has Schwastek sign, there will be spasm or twitching around the angle of the mouth, or even spasm of hemifacial spasm, depending on the severity of this, the hypocalcemia. Okay, so let me show you a video to demonstrate Schwastek sign. Just let me know once you see the video. Can you see the video now? Okay, is the video okay? Now look at this area here. The doctor is tapping here, and look at what happens here. Okay. Can you appreciate the twitching? The video is not moving properly. 1 second. 1 second. It's not moving properly. Can you see it now? Can you appreciate the twitches? Here. Okay. Can you see? The other side is even more obvious. Can you see? Is it clear? You want to see the video again? Huh? Can you please answer me?
I think it's clear.
Okay. Okay. Let's continue. Let me share the slides again. Just tell me, please, when you see the slides. Are my slides visible again?
Yes.
Okay. Are they in slideshow? Okay, then we have the Trousseau sign. The Trousseau sign. The Trousseau sign, this is how you do it. Actually, first of all, you measure the blood pressure of the patient in order to detect the systolic blood pressure. And then you tell the patient, because this test is very painful to the patient. Okay, you tell the patient, I'm going to test to do an important test, but I need to raise the pressure inside the cuff for 3 whole minutes. Okay, so please bear with me. I know it is going to be very uncomfortable to you or even painful, but please bear with me because this is a very important diagnostic test. So here, suppose the blood pressure of the patient is 120/80, okay? So the next thing you do is you raise the pressure inside the sphygmomanometer cuff to 10 millimeters above the systolic pressure that you measured. That is to 130, okay? And you maintain this pressure for 3 minutes. Why for 3 minutes? Because if the patient has a mild hypocalcemia, the test may be elicited at 2.5 minutes. So if you just wait for a few seconds and nothing happens, you may think it is negative, but actually you have to wait for 3 whole minutes. Okay, you ask the patient to keep the hand open like that, and then the first thing that happens is there will be adduction of the thumb, and then flexion of the hyperextended fingers like that, with adduction of the fingers, and then finally flexion of the wrist and elbows. All right, I will show you a video to illustrate this test. This is Trousseau sign. Just let me open the video first. Yeah. It's opening. Okay, let me share the video with you. Is it difficult what I'm trying to explain to you? Huh? Have you seen all that in the cases you have seen or presented at the scientific meeting? Have you seen these tests? Huh? So here you can see the hand is open like that. The doctor has raised the pressure in the sphygmomanometer cuff 10 millimeters above the systolic blood pressure that was measured earlier. You notice here, you see the thumb is starting to adduct. The fingers, the extended fingers are starting to flex and adduct as well. Okay, And finally here, you see, the wrist is starting to flex as well. You see, of course, the hand here is starting to turn purple in color because of the raised pressure. Huh? Can you appreciate that? Did you see? This is how Trousseau sign is done. Okay, is it clear? Any problems so far? Okay, any problems?
It's good, doctor.
Okay, let me share the slides again. Can you see the slides? This is how tetany appears like. I mean, the patient, the male patient I told you about, the one with the tracheostomy tube in place, he presented to the ER like that with carpal and, of course, pedal spasm, spontaneously without eliciting any Trousseau signs. But he didn't mention this. He just mentioned the stridor and the suffocation. Okay? Anyway. Now coming to the investigations of hypoparathyroidism, regarding the lab, we have low serum ionized calcium. We have low 24 hours urinary calcium excretion, high serum phosphate, and low PTH level. What there is a normal alkaline phosphatase level. In hyperparathyroidism, there is the opposite. There is high calcium level with a high urinary calcium excretion, low serum phosphorus, and high PTH, but alkaline phosphatase in hyperparathyroidism is elevated. Why is alkaline phosphatase elevated in hyperparathyroidism? Who can tell me? Who can tell me?
due to البوني تيرن اوفر الاكتيفيتي بتاعته.
From which cells does the alkaline phosphatase come from? From the osteoblasts, from the osteoclasts, or from the osteocytes?
فقد الاوستيوبلاست.
Osteoblasts, yes, because whenever there is high bone turnover, the osteoclasts are very active. They are very avid. They cause bone resorption. Okay, in that case, the osteoblasts become active in order to form new bone. So they are rich in alkaline phosphatase, the bone alkaline phosphatase. This is why it becomes high. But here, this is not the case in hypoparathyroidism. So you will find normal alkaline phosphatase level. All right. When you do a CT on the brain, here not on the sella turcica, but on the brain, okay, at the area of basal ganglia, you will find basal ganglia calcifications. Like here, this is an axial cut. This is anterior, this is posterior, this is right, this is left, and this is the bone of the skull. It appears white, okay? This is the brain tissue. It appears grayish in color. Here it is without contrast. This is actually the area of the basal ganglia. So here they appear white, almost the same tissue density as that of bone because they contain calcium, okay? And when this is a very common finding in hypoparathyroidism. Okay, is it clear? Now, the last thing I want to revise with you is are the conditions that are similar to hypoparathyroidism. We have two conditions. Pseudo, whenever I read this word, Pseudo, this is Greek for false. Pseudo hypoparathyroidism. So it's a false hypoparathyroidism. But then we have a pseudo, a false pseudo hypoparathyroidism. What is this confusion? Let me tell you. Pseudo hypoparathyroidism, these are several clinical disorders characterized by end organ resistance to PTH. Okay? This is pseudo hypoparathyroidism. Here, they are associated with hypocalcemia and hyperphosphatemia like hypoparathyroidism. But what is different is that in hypoparathyroidism, the PTH is low, right? Here, you will find it increased, okay? And they have target tissue unresponsiveness to PTH, which manifests as lack of increased cyclic AMP excretion in response to PTH administration. How do we do this test? I have never done it here in Egypt, actually, but I have done it abroad. I was working a long time ago in Saudi Arabia, and there came these two sisters, having pseudo-hypoparathyroidism. So I sent them to do this test. They measure the urinary cyclic AMP level, and then I gave them PTH, okay, and then I measured the cyclic AMP excretion again following PTH, and I found no increase after PTH administration. This signifies that the target tissue, obviously speaking the kidneys, it's unresponsive to PTH, okay? So this is how I diagnosed them. Clinically, they appeared like that. Both of them were short. This is not a girl. This is a lady, okay? She has short stature, okay? And she has disproportionate shortening of the limbs. You will notice that her legs and arms are shorter compared to the height, okay? She has generalized obesity and a round, flattened face. And the mentality, maybe they may have also subnormal mentality, okay? If you look at their hands and feet, but particularly the hands, you will notice they have brachydactyly. This means what? There is shortening of the 4th and 5th fingers, okay? And a greatly shortened thumb, okay? And it's wide. It appears like the thumb of a potter, okay? Because the thumb of a potter doing having to do the pottery all the time becomes eroded, so it becomes shortened like this thumb, okay? Now, if you ask the patient to do a fist, please do a fist, you will notice there are knuckles here, right? But where are the knuckles of this patient? Instead of the knuckles, there are pits. There are pits. Why? Because the 4th and 5th metacarpal bones are shortened, giving, instead of the normal heads here, the heads are located further proximally, so the pits appear instead of the heads, which form the knuckles. This is called Archibald sign. No need to remember the sign. Now, if you do a plain X-ray, this is the plain X-ray of the hand of this patient, you will notice that, you see, there are short 4th and 5th metacarpal bones compared to the 2nd and 3rd metacarpal bones. So this is what caused the pits instead of the knuckles, okay? Is it clear? Now, what is pseudo? False pseudo. This is a plain X-ray of the right hand in AP view of a 40-year-old female patient wearing a nice ring like that, showing she has a short 4th and 5th metacarpal bone, okay? The 4th and 5th metacarpal bones of her right hand are shortened, exactly like in pseudo-hypoparathyroidism. But the lab shows normal serum calcium, normal phosphorus, and normal alkaline phosphatase, and obviously also normal PTH. So pseudo-hypoparathyroidism signifies that there are the phenotypic defects, but with no abnormalities of calcium metabolism. Okay? Is it clear? Any questions so far?
Yes, doctor.
We have concluded this was supposed to be the 3rd part of the revision. The final part is about the adrenals. I think I can do it with you before your final exam, inshallah, if you like, if you have time and if you like. Okay? Now I have put like last time the survey about today's session in the chat of Microsoft Teams. Can you please verify if you can see it? And I'm going to share my screen with you again in order to show you. There are the same questions as last time, so I hope it's not going to take as much time as last time. Okay, see now there are no responses yet. The questions are the same. The timing of the session was appropriate. The duration of the session was appropriate. The session was well organized. The content of the session was very clear. The instructor was well prepared. There was adequate time for asking questions. What did you like most about today's session? What would you like to change in this session? So kindly, please answer. You are, how many are you? You are 6 students. 6 students survived. I'm actually very disappointed because I wasted a lot of my precious time in order to revise with you, but you are like 26 master degree students, but only eight of you cared to attend. This is really very sad because I'm doing this revision for you, not for myself. Obviously, I know this. You need to know this. Okay. Did you find the survey? Dr. Molisu, could you open it this time? Can you still see my slides? Okay, I have one response. Okay, Dr. Molisu, were you able to open the link today, this time? Huh? Can you please answer me?
دكتور هو اللينك مش باين عندي.
اللينك مش باين عندك. طيب I will share the link again. مين اللي بيتكلم؟ دكتورة مين؟ Doctor who is talking?
خلود يا دكتور.
Dr. Khulud. Dr. Khulud unverified. I put it again in the chat. Please see if you can. Can you see it now? Huh? Can you see it now, Dr. Khulud? Dr. Khulud.
Yes, doctor.
Okay.
Yes.
Type Dr. Molisu, what about you? Did it open? I mean, is it active or is it like last time? You can't check. You can't click. Dr. Molisu, are you there?
Yeah, I'm here. I'm trying to
open
it.
Okay.
Yeah.
Let me know, please, if you could open it or not. Okay. Now I have 2 responses.
Okay.
Yeah. Make it quick. 4 more students remaining. Any questions so far? Anything that was not clear or something that you want me to repeat? Anything you want to ask about, either about today's session or Monday's session? Feel free. We still have time until all of you finish responding to the survey. Any problems? Any queries? Any problems? Come on, guys. What's taking you so long? 3. Now 3 more remaining. Any questions? And like last time, please, who finished responding to the survey, please remain online because I'm going to read to you the results. Everybody knows what he or she wrote, but it would also be nice to know what your colleagues think as well. Can you please hurry up? Because we're really very tired, all of us. Any questions, any queries, any problems, please let me know. Ya Musahil, 2 more remaining. 2 more students. Okay. Will you please hurry up? Can you still see my screen? So I'll start reading the responses to you. 1 more remaining. The timing of the session was appropriate. 80% strongly agree. 1 is neutral. I hate actually when somebody, a doctor particularly, writes neutral, no opinion. The duration of the session was appropriate. 60% agree, 40% strongly agree. The session was well organized. 100% strongly agree. The content of the session was very clear. All of you strongly agree. The instructor was well prepared. All of you strongly agree. There was adequate time for asking questions. All of you strongly agree. What did you like most about today's session? The clinical scenarios and the photos, very informative regarding signs and symptoms, extremely helpful. Thank you for your time. You're most welcome. As I mentioned, I'm here for you. Okay. Well organizing and clinical science, informative pictures, radiology imaging. What did you like to change in this session? Nothing at all. Maybe later we could discuss the management. That would be a helpful addition. Yeah, if you like. I suppose you know that already from the session, the scientific meetings and from your studies. I have no problem, but it would take more time. Yani on Monday, we remained almost 3 hours plus, right? And today as well, we remained 3 hours, okay? So it would add to the timing, yani, in case that you complained about the long time last time, if I remember correctly. But I don't mind. Anything you want, I can do for you, okay? So any other questions or any other queries before we leave? I thank you very much for your attendance and for filling out the survey. And I wish you the best of luck on your upcoming midterm exam. Okay, I'll see you, inshallah. in the next scientific meeting at the endocrine division. Assalamu alaikum wa rahmatullahi wa barakatuh. Have a good night and happy dreams.
شكرا يا دكتور.
Thank you, doctor.
You're most welcome. Bye.